So good afternoon, everybody. My name is Pauline Irungo, and I'll be your moderator for the day. But before we go so far, we'll just take a few minutes to enable participants to join. But my request is that all our participants, please keep your videos on, even though you're muted, so that people can see you and people can know who is speaking to them. Thank you. And we'll, in about 3 minutes, we'll start. So afternoon, our participants, our panelists, welcome to this webinar series. I'll reintroduce myself. My name is Pauline Irungo. I work as the advocacy and policy lead for the country program of PATH. And with me are a panel of distinguished guests. But before we get to the point where we know who is speaking to us, I just want to acknowledge that we have quite a sizable number of people. I think we're over 50 people on this call. So we're looking forward to a really lively discussion that will give us value as we think about prioritization of health research and development and innovation in COVID-19 response in Kenya. I think if you think about it, the conversations around health research have not really been a very big topic nationally over the many years that the country has been participating and has built institutions, but we've never gotten really to that point where we bring research and development and innovation to the center of our health response. So we hope that out of this conversation, you'll be excited, you'll also join the team and people who are really interested in ensuring that Kenya turns around and becomes an economy powered by innovation, research, and development. If you look at our Vision 2030, it very clearly puts down that we want to be an economy that's powered by knowledge. And knowledge really comes out of research, innovation, and development. But even as the country responds to COVID, we've seen bigger calls for research and development innovation to be prioritized much further. There is a road to walk, and I think needs to be walked by all of us. But before we jump into the real tough conversation and cracking this, I want to give us a few things. Let me start off with logistics. First, this is an interactive session. So we want to not just hear from the participants, from the panel, but we also want to hear from you, the participants. So please feel free to use the chat and the question and answer buttons at the bottom of your screen so that you can put in your questions, you can put in your comments and contribute to this conversation. As we get along, we'll make sure that we are reviewing those and that issues are being responded. We'll spare the last about 30 minutes to make sure that we really focus on the comments and conversation from the participants. The other thing is we also want you to not just share within this particular forum, but also to use our social media platforms so that we can get this message to even those who haven't been able to join us and spark a bigger conversation. So please go online, tweet, and make sure to tag at PATH Tweets, at PATH Advocacy, at CHReaD Kenya, and at AMREF Kenya. And the hashtag we're using is R_ND_4, as in number 4, and then COVID-19 as one continuous word. I'm sure when our host will put that up, as well as the handles to tag, so that we can be able to follow the conversation online. Another thing is that this call is being recorded so that we can be able to generate a report, but also to share it a little bit more widely to even those who are unable to join us for one reason or another. So please note that it will be recorded and it will be shared. So I want to thank everybody who is joining us and for all your contributions, not just to the health sector, but in specific fighting COVID-19, just to ensure that we all reduce the impact of the pandemic in our lives, and not just the lives of Kenyans, but also for Africa as a continent. And as we make this conversation, the format is really to ensure we can engage deeply, we can raise questions. So feel free to raise really critical questions, raise issues that are unclear, so that we can be able to take this conversation, either get a response here or even to spark further thinking through how we move research and development forward. So this webinar is hosted by the Coalition for Health Research and Development. But the coalition is hosted at PATH. And in a few months, we'll hand over the baton to AMREF. They'll be the new host in a few months. So if it's a good partnership for us to be part of a coalition, but also to grow the coalition. There are many of you who may not have had or interacted with the coalition. So this coalition brings together a number of civil society organizations, research institutions, private sector organizations, and it was established in 2015 with the core mandate of advocating for enabling policy, regulatory system strengthening, and a better financing environment for research, innovation, and the process of product development, so that we can be able to access good quality products as Kenyans, and I think contribute even to the region. So the coalition is an open platform. Institutions and organizations that are interested in advocacy for health, RD&I, allow me to use that short, can be able to reach out to either PATH or to AMREF, and they can join the coalition and become members and play a part. So let me stop at that in terms of introduction. I don't think there is need to introduce AMREF and PATH. I think these institutions have been in the public health space for a time now. So I think we can be able to find them and we know them. So let me stop at that. Let me pivot and introduce my distinguished panel. So today we're joined by a number of key speakers, leaders in this sector. So let me start off with Dr. David Kariuki. Dr. David Kariuki is a Senior Deputy Director of Medical Services and Head of the Department of Health Policy and Research and Development. He was previously the head of Universal Health Coverage Coordination in the Ministry of Health under the government of Kenya. Welcome, Dr. Kariuki. So you'll see him speak in a few. My next speaker is Professor Omu Anzala. Professor Anzala is a professor in the Department of Medical Microbiology at the University of Nairobi, and is also a director of CAVI, the Institute of Clinical Research, CAVI ICR. Next is Ms. Lynette Amolo. Lynette Atieno Otieno. Oh, I like that. Atieno Otieno is the Senior Regional Communications Manager at the Drugs for Neglected Diseases Initiative, RD&I, the Africa Regional Office based here in Nairobi. And RD&I, she note, is a non-profit organization. And last but not least, I am really, really pleased to introduce Professor Elizabeth Bukusi. She's a professor with quite many publications under her belt. And I must say that among people who helped me to learn about health research is Professor Bukusi. So I see her as a mentor and a contributor in my life, as well as Professor Omu Nzala. They taught me a lot in my early days of trying to figure out what is health R&D. So Professor Bukusi is, she's earned her PhD from the University of Washington, Department of Epidemiology, as she has a postgraduate diploma in research ethics from the University of Cape Town and a master's in bioethics from Center for Bioethics and Culture at the CHReaD Institute of Urology and Transplantation in Karachi. So she's done quite a lot of work. She's a chief research officer at the Kenya Medical Research Institute and a research professor at the University of Washington and an honorary lecturer at the Aga Khan University here in Nairobi. So welcome, distinguished panelists. We look forward to really a deep conversation and a very exciting one too. So let me start off with Dr. Kariuki. Dr. Kariuki, please share with us the overview of health research development and innovation in Kenya so that you put us on the route to having a good conversation. As Americans would say, please help us to put this show on the road. Over to you, Dr. Kariuki.
Well, thank you very much, Pauline. Right, participants, is Dr. Kariuki. I think that it's quite important for us at this time and having this conversation at this particular time, because the current crisis that we are in has called for a need to invest much more than we have been doing when it comes to research, development, and innovation for all kinds of health products and technologies. It wouldn't have been more appropriate than having it today, probably even much earlier. We really need to focus ourselves into activities that will enable research to be provided with the enabling environment in terms of policy, regulation, and financing mechanism that will help us facilitate the access of products that will be translated into technologies that will eventually improve the health of every Kenyan. I think as a country, we have taken some steps in the recent past to be able to improve research. In terms of policy, we recently had the launch of the Research for Health policy framework that is actually a response to SDG 3 and the World Health Report of 2013, where research for UHC in terms of setting out priorities for research and achieving universal health coverage became one of the main priorities for targeting towards achievement of UHC. So in Kenya, we did that, and with the support of all the partners that are involved in the research space, this framework was launched early this year by the Cabinet Secretary. We also have the sector policy on research. These were launched together, and we hope that were it not for the advent of the current crisis that we are in, we would already have set rolling in terms of implementing both of these documents that would now set the agenda in terms of even telling us and directing in terms of how to utilize the available resources. We know that research for health in Kenya has been lagging behind generally largely owing to difficulties or weakness in terms of getting adequate funds, and also not being quite well coordinated in terms of the research that has been done, maybe sometimes duplicating, because different institutions, organizations may be conducting research, along same lines. We also have been having previously no laid down framework, and this current framework will help to align us through the technical working groups in ensuring that people collaborate more and we are able to get more and translate more from the researches that we conduct maybe locally. Looking at the regulatory side of research for health, we as a country have various documents that would guide research and the various institutions that are involved in conducting research, whether it's the research institutes, the universities, schools, individuals, or such. Starting with the Science, Technology, and Innovations Act of 2013, I think it provides an overarching framework together with the recent Health Act of 2017, Part 14, between sections 93 to 100, envisage a need for, investing and, providing an enabling environment in terms of regulation for conducting of research, which has actually also proposed the formation of a national health research committee that will guide the development and implementation and monitoring of research for health activities across the country. During this crisis that has come around COVID-19, and I believe we are actually in the final processes of this formation of the committee. One of the major problems around research for health has been in financing. We, in the country, we have the National Research Fund under the National Council for Science and Technology, and it is being proposed that part of the funds of this committee, and it's proposed that at least 30% of the funds of the National Research Committee be channeled towards research for health. We believe that this, as a country, will increase the amount of funding that we, as a country, using national budgets, are put towards specifically for health activities. This will come to augment what traditionally has come from funders of research, which sometimes gets targeted towards the funding partner objectives. But we also now need our own homegrown additional budgets that will guide more of the priorities that we have across the national and sub-national level. So we are hoping that maybe this series of webinars will help us increase our understanding in terms of health research, development, and innovation and its processes, and the value of research in improving the health of our people.
Dr. Kariuki, we are having trouble hearing you. And you're muted.
Yes, Pauline, I think I got lost a bit, probably network. I was saying that probably I could have stopped there for now and maybe welcome more contributions and questions as we progress on. Thank you very much, and apologies for that disruption. Thank you.
Yeah. Thank you so much for laying that background to us, sharing the situation of policy, the regulatory as well as financing, and emphasizing the need for homegrown solutions that are also funded locally. To take us further, let's welcome Professor Anzala. And my question to you, it's a very loaded one. When we talk about health research, development, and innovation, what does this concept entail? Because like Dr. Kariuki said, that this series of webinars should help us increase understanding of research for health. So what does this concept entail? And what is the process of conducting clinical trials, and are clinical trials safe? That's a very common question. Whenever you talk about research and development, people wonder, is it safe? And how do we translate the results from clinical trials into medical products? What ethical measures are in place to protect clinical trial participants and communities in Kenya? So, Professor Anzala, please share with us your thoughts. If you're speaking, you're muted. Please unmute.
Okay, hello everybody.
Hi, Prof. Karibu.
Yes, I'm glad to be here. Sorry, I'm on top of so many other things. I'll be brief, and maybe I have to leave now. You know, the whole issue of just a minute. Excuse me, can you get the other speaker to go on, and then I can come in last, please?
That's fine. So so then let me pivot to Professor Bukusi. Are you okay if I bring you up first and then I go to Lynette and finally Dr. Anzala, Professor Anzala?
That's all right.
So Professor Bukusi, Karibu, speak to us about why does Africa need to invest in and participate in health research, development, and innovation, including clinical trials?
That's a great question, Pauline. Let me tell a story, because maybe that will help us figure out, do we need to invest in research? So let me tell you part of my story during this COVID-19 period. On the 12th of March, I came back from South Africa, from the University of KwaZulu-Natal, where I had been conducting a mentoring training for a group at UKZN that's called Thrive. They're an NIH-funded group. They're building capacity for African researchers by training masters and PhD students. I'm passionate about building capacity and training. And as Pauline said, I've had the joy of interacting with her and many other brilliant young Kenyans who I really think will make a difference for health and research for health in this country. So I came back and arrived, and then now on the 13th and on the 14th, we had a conference. The Bioethics Society of Kenya, that's building capacity in bioethics knowledge and information, was running a conference. While I was at that conference on a Friday the 13th, I remember so clearly, at lunchtime, that's when the first COVID-19 positive individual was announced in Kenya. By that weekend, the president and the cabinet secretary made an announcement and said, if you have traveled in the last week or two and have been to a country where there were people who are testing positive for COVID-19, self-quarantine. I had just come from South Africa, and prior to going to South Africa, I had been in Geneva. Both countries had individuals who had tested positive for COVID-19 earlier than Kenya. So I went into self-quarantine. So I asked my family members not to come into my room. I was being handed food at the door in gloves. People were sanitizing, washing their hands, using alcohol sanitizers. And I kept thinking, watching myself, might anything develop? And I was concerned because among my family members, I do have one of my young family members who was expecting a baby then. My granddaughter has been born now. And I was really concerned because I'd been in contact with them that weekend before the announcements were made about self-quarantine. Now, as a medical doctor myself and someone who's in research, of course, I always think of the worst possible outcomes. Thereafter, let me just briefly touch on something else, and then I want to bring it back to why we need research. I have a house help. I know all Kenyans and all people working in Kenya, we all have some kind of domestic help to help us keep our chores. So she came in and you know, she would only come into the door and she kept asking me, are you sick? Now, because of my schedule, usually she doesn't see me. She comes to the house when I have left and she leaves the house before I've come back. Now, she kept asking me, are you sick? I said, no, I'm not sick. So why are you keeping a distance? I said, I don't know whether I've acquired an infection. I've been in a place where there has been infections of COVID-19, and therefore I'm keeping with what the government has said and self-quarantining. She said, you mean this COVID story is true? I asked her, what do you mean it's true? She said, oh, I thought the government was just making up a story, because people think that the government is just saying it to the WHO and the UN bodies will give them money, and so that we get more money in Kenya. Now, I'm telling that story to illustrate two things. Number one, we need to do a lot in terms of research and development, because even just advocacy at the community level is really important. People don't understand why we do research or what research is for. But as a researcher myself, we do need research, because the question I would ask you is, does it matter? And if it does matter, why does it matter? And to whom does it matter? I was concerned that I could have an infection. I was concerned that I could pass it on. I was concerned because we don't know how to deal with it, how to treat it, what works, what doesn't work. We had very dire pictures in the early times, in March and April, when we were worried about what would happen in this country and in other sub-Saharan African countries. It hasn't quite happened as had been anticipated. And the question is, why? If we do not do the research, if we do not understand what is it about our epidemic, then what can we do about it? As research has gathered momentum, as information has been collected, we're starting to learn a little bit more about what can we do to actually manage people with SARS-CoV-2 infection. We're actually starting to learn about what can we do to prevent it? How can we ensure that we minimize its impact? Without this information, we can't make decisions. Right now, people are worried. Yes, the economy has been hit. There are people who are really struggling. We see reports of Kenyans who are unable to pay rent, who are struggling to put food on their tables. We're struggling with the mental and psychological and social effects that you can't shake hands, you can't hug somebody. Children are worried. They haven't been to school the whole of this year. The fallout from children not going to school is also going to be enormous. We're not even talking about just issues of domestic violence or sexual abuse, or the pregnancies that we think may be resulting from young women who are not going to school, who are not occupied, who end up getting exposure, and whose education may even be disrupted. But we're talking about so many other psychosocial effects that we don't even understand. If we do not put money to understand these things and deal with them, who will? We need to ask ourselves, is there a concern? If there is a concern, whose problem is it? If it is a problem, who needs to resolve it? We cannot wait to say that whatever solutions work for Italy or Germany or the United States will work for us. We have to find our own homegrown situations and our homegrown solutions. We can only find it if we take the initiative to find out what is our problem and how do we resolve it. Thank you, Pauline. I will rest my case.
Thank you so much, Professor Bukusi, for those really insightful comments. As we think about the solutions need to be homegrown, we can't wait. And I think the COVID pandemic, we all can agree, has changed the way we think about global health and health in African health. So because it leaves us no choice but to take steps that we haven't boldly taken in the past. I think let's pivot a little bit and talk about, have a discussion on health research and development innovation are not commonplace in Kenya. This is a question I'm asking to Lynette Atieno. Please talk to us about what needs to be done to increase awareness and understanding of health research, development, and innovation among the public. Because you're a communicator, so this is an area that we could do with a lot of help in terms of thinking, how do we take this message to the public so that it's not just a demand coming from science, it's also a demand coming from the people and appreciation of the value of research, development, and innovation. Lynette, over to you. Thank you.
Thank you very much, Pauline. I think Professor Bukusi has really has started the process of trying to, ask the questions about who is involved and the value of awareness among the public, and I just want to continue that conversation. One of the things that I just want to emphasize first is that the public is a very important stakeholder when it comes to research and development. They are the consumer of information. They are the consumer of the new tools. So the research and development that Professor Bukusi was speaking about, the public is the consumer. We cannot ignore them, you know. They are also the ones that will participate in clinical trials or research activities. And so we cannot ignore them and take a passive role in terms of their information. But if you can look at the example of COVID-19 currently, you can see the level of understanding that the public has on research and development and innovation. One of the things if you can see in most recent reports has been the fear and mistrust of the unknown. You know, I feel like if people are not informed, then you have a fear of something you don't know. Because you see an activity happening, but you do not understand why, and Professor Bukusi has alluded to it, why it's being done, when the results will be available. You have no idea, and because of that, it brings out this fear and mistrust among the public. And for that reason, the public's understanding of research has remained very limited, you know. And we can have examples, like recently in South Africa, you saw that the public was up in arms when a vaccine trial was started. And you can also see on the other side, on the flip side, when some of the scientists from France spoke about clinical trials that they desire to be conducted in Africa, and the backlash towards that. So you can see that there's sort of a gap in terms of information between public and the scientists. There's just something that is not going right. It's like the scientists feel like they are speaking, and the interpretation of the public is very negative sometimes. We can say that there has been quite a lot of strides made over the past few years about information in the public, but we can still do more. But I have to ask myself, and for us to ask ourselves, why is this the case? Why is there a lot of negative information, misinformation out there? And one of the things is what Dr. Kariuki was alluding to. There's a role that the government needs to play, for one, in terms of investment, of course. There has been some strides made over the past 10 years about allocations, you know, in finances and things like that. But still, I feel we realize that there needs to be more engagement of the government, because not only is investment important, but there's also the place of having ambassadors, having people who can speak about health R&D in the public purview. That is very important. We need to have people at national level and also at county level being able to speak about the role and the value of health research and development. We need ambassadors within our government structures, literally, to be able to bring out these messages, because people listen to leaders, and if we have leaders who can be able to speak strongly about this, then the public will be informed. There's also, you know, science and research, it's complex. The information that comes out of that is a bit complex. And sometimes we have not done a very good job at being able to translate this kind of information to the community, to make it simple to non-experts, if I can say that. And it's very interesting, as I was listening to Professor Bukusi, who's a scientist, and how she has been able to break down information that is complicated. And I feel like this is how our scientists should be communicating, you know, simple information from, yes, it's complex, but it can be put in a simplified manner. We also have one of the most important disseminators of news, which is the media. And sometimes the media has not prioritized content of science, because there's a lot of information out there. And even the taste buds of the public have sometimes defined how the media reports. And so we actually need to, you know, approach this in a two-pronged way. Make the taste buds of the public desire information, and therefore the media will have to be reporting on this information. So we really need to build the capacity of media, because they can actually play a major role in setting the agenda for people to have appetite for this kind of information. I've already spoken about scientists and researchers' role, and what I realize sometimes is researchers communicate and put things in scientific journals. I've read some journals and I'm like, wow, if this information was only out there in the public affecting policy, changing things, it would be really great. But you see that sometimes they put that in the journals and they go and speak to their peers in scientific conferences, and they forget about communities and stakeholders and policymakers, who are the ones who actually lead to policy change, who define policies that affect the new tools and new innovations being valuable to the public. There's also cultural misconceptions amongst communities. I've worked in a project where we're trying to find out the preventive nature of bed nets, and when this was distributed, and I'm sure some of us heard about it, some people didn't even want to use it because they felt like they can see ghosts. And I feel like we realize that information will actually make adoption of some of these new tools become more embraced. So in terms of just quick recommendations, the first thing that we really need is linkages between researchers and policymakers. These two people need to talk, and as well as communities. We have to have networking sessions. We have to have the researchers busting the myths that exist in terms of clinical research, R&D, and innovation. And so we have to have more forums where we bring these two people together, because it's only in that way that there can be fast tracking of translation of research into policy. The second thing is we need more ownership and investment in R&D. Because what the leadership values is what the community will value, So we need more investment, be it human resource, be it budgetary allocation, be it just information out there that is being, communicated by the leaders. We also need capacity development of both the scientists as well as the media, because we need scientists to be able to communicate to non-expert audiences, not only for them to talk about their results in this complex manner that sometimes they do. And we also need the media to understand, to be able to interpret these results, So we already have structures maybe within the media. Some of them have science desks and they have specialized journalists, but we also need more people in this area so that we can have more people who can report on this content more effectively. And we need to cultivate ownership amongst the media. Maybe even coalition groups like CHReaD can be able to have media people as part of the membership, so that they understand what's going on, and they can be able to communicate more effectively. The final thing I can say is that there's a lot of fake news out there, and we've seen that in this time of COVID-19. It's not only limited to this time. We've seen it when it comes to HIV research. We've seen it in NTD research all across. And so we need to actually partner with fact check websites, to determine if the information is fake or not. And we realize that if all these components come together, there'll be a ripple effect. If there is free flow of information from the scientists, policymakers will be able to make informed decisions. The public will be able to agitate for policy change. They can communicate to their MCA or whatever it is. They will be more aware, understand more about the process of research. The media will be able to communicate better. And I feel like when this happens, the ripple effect will happen and there'll be more awareness out in the public. Thank you. I'll stop there.
Thanks, Lynette. I cannot even dare go beyond what she said. She said it really well, and put it down a challenge for both science, for all of us, to ensure that we're communicating in ways that reach the people and build confidence in science and appreciation of the value of science. So, Professor Anzala, I hope you're ready now, because your question is a very loaded question. Should I go ahead?
Yeah, go ahead.
All right. So, Professor, When we talk about health research, development, and innovation, what does this concept entail? So that's one. Two, what is the process of conducting clinical trials? And are clinical trials safe? How do we translate the results from clinical trials into medical products or practice? What ethical measures are in place to protect clinical trial participants and communities in Kenya? So really zeroing in into almost what you do every day. So over to you, Prof. Anzala.
Okay, thank you everybody. I'm glad to be here under the circumstances of COVID. I thank the organizers for getting me in so that I can also, participate and give my thoughts and a bit of my experience. In terms of health research and development, really what has crippled Africa, because I've been in this process maybe all my life, when I finished school and everything else all my life, what has really crippled Africa and crippled Kenya, I'll be very straightforward and categorical, is over-reliance on CDC and WHO. That's where the problem begins. To the extent that even if you are in your own country and you are doing research, your research will not translate into policy unless it is translated through these organizations. What does that mean? Then it means that our own countries have no research agenda for health research and development. And that's where the problem comes. So we must begin to have a different narrative. And COVID has actually opened our eyes. My involvement at the Ministry of Health and my involvement in the task force has actually assisted the ministry to begin to look different and to begin to realize that the expertise they are always looking for outside, that expertise actually exists in this country. If I may speak for Kenya, because I don't know what is going on in Uganda, in Tanzania, and the other countries. So for us, really, that is actually what was a big eye-opener. So these two organizations, we must look at them very, very critically when we come up with our own research agenda. And that research agenda must be developed as quickly as possible from maybe the national, from NACOSTI, and then that health research agenda can cascade to universities, to institutions, even to hospitals. The other problem I've also realized that you can look at a community level, you can look at the level of policy, but even at the level of healthcare workers, there are a lot of us healthcare workers who actually don't appreciate the value of research and how research can actually influence practice. So when we talk of communication, please let us not forget healthcare workers. I've talked to many healthcare workers whom some of them, I'm sorry to say, believe that a measles vaccine just dropped from heaven. It was just there. Because when they were born, the measles vaccine was there. When they grew up, it was there. So, and then now that leads me to vaccines. And we need to communicate issues like, why are vaccines made? How are vaccines made? How are they then tested? And how are vaccines eventually introduced into the market? And don't take, ladies and gentlemen, it might sound very simple, but COVID has actually taught me a lot of things, that in the entire system, we have a lot of work to do in terms of ensuring communities, the policymakers, and even the healthcare workers who should be advocates of vaccines are actually very well educated, well informed, so that they can actually make very good informed decisions. Because some of the skeptics when information came from Oxford, and the gentleman who was speaking from Oxford is a gentleman we have worked with, and he was very genuine because we have tested a lot of phase 1 products with them here in this country. So I don't want to take long, but in terms of the processes, first of all, let's realize that vaccines are given to normal people. Vaccines are not given to people who are sick. Vaccines are given to normal people. So you don't want to give a vaccine to a normal person, and you don't want that vaccine to cause any major untoward effect. That is the beginning. So the second thing is that vaccines, for that reason, are critically regulated from the first thing, designing the antigen itself. And that means you understand the natural history of that infection. So from that natural history, you design the antigen. Once you have designed the antigen, then you begin your small animal studies in the lab, usually mice, to look at safety and whether these things induce any immune response. If that goes well, then you move on to large animals. And these are usually non-human primates, okay, to give you a sense that is a vaccine safe? Is a product tolerable? Does it cause any side effects? Does it induce the right kind of immune response? Then once that has been established, then now you move on to preclinical trials in non-human primates to ask yourself again, is it safe? Does it induce an immune response? And in animals, then we can do what we call challenge studies to find out does that vaccine prevent infection, or does the vaccine prevent the disease? So all this has to be established before you can even think of moving to humans. And this takes years. A lot of products never go beyond small animals. A number of products never go beyond non-human primates. So once this has been established, then now you go to M&D, good manufacturing practice, where a pharmaceutical company will actually make a product that then can now move from preclinical to clinical trials. And then you begin your phase 1 safety, your phase 2 extended safety and immunogenicity, and then phase 3 where you are looking at extended safety as well as efficacy. And if all goes well, then now you move from that extended efficacy, safety efficacy to now phase 4, where you are looking for effectiveness. And effectiveness is now the issue is that can you actually make that vaccine at a cost that you can deliver it to the populations in enough doses, and can it actually withstand the logistics from the production, toxicity studies, safety, and then moving on into logistics of production, to the warehouses and eventually to the end user. So I don't want to go into those detailed processes, but that's what it actually takes to move a vaccine from the antigen to the actual product in a vial. The vaccine that took the shortest from the processes I've discussed was actually the mumps vaccine, which took about 10 years. And that was actually the shortest period that a vaccine has ever been developed. But because we knew the correlates of protection were known, people recover. So all those things were there. So that vaccine took only 10 years. Now, COVID, there's talk of expedited movement and what have you. But in between all that, during the animal studies, there are animal regulations that regulate that. When we get into humans, there's now the good clinical practice, the good clinical laboratory practice, the good manufacturing practice. At every juncture, regulation must be there, dossier must be available for you to move from one stage to the next stage. And eventually, as you are doing this, ladies and gentlemen, you are preparing the community. For example, now, we are trying to look for funding at CHReaD to start preparing communities for a possible phase 1 or a possible phase 2 or a possible phase 2B to just try and educate the communities as well as the policymakers that we need to also test this vaccine in our own environment. We need to understand whether these vaccine products will actually work within our own setting. Because I'll also give you an example. I've always said this, that we are, as human beings, we are similar, but we are not the same. The way a vaccine will behave in the pediatric age group might be different from the way the vaccine will behave in the elderly. We also talk of pregnant women. We also talk of vulnerable groups. So this discussion must actually be ongoing right now as to if the COVID vaccine is actually realized, how will we introduce it in our own communities? So there are all these layers. But even before it is introduced here, that vaccine has to be licensed in our own country. So what will be the process of licensure in Kenya if Kenya has not participated? Who will they rely on? And this is usually the problem. They fall back on WHO. And that's where, for me, I'm sorry to say, that's where the disconnect begins. Then we never have any homegrown information of our own that we can actually rely on to make certain decisions. So we must think hard and think critically, how do we ensure that as well as we work with these organizations, the CDCs, the WHOs, and what have you, how do we ensure that we as our own are also in that space in terms of influencing policy and practice? But those two organizations, I'm sorry to say, have been at the forefront of ensuring that local scientists are never listened, because every time WHO, every time CDC, but you have actually seen now, the US is suffering COVID, just like everybody else. So you cannot sit and say that somebody else knows more about COVID than another person. We have been learning as we go. And that is what we really need to use COVID, this space of COVID, to position ourselves as local scientists, to begin to work with our communities, to begin to work with policymakers, to begin to work with our healthcare professionals, and to ensure that we can do meaningful work that can actually influence policy and practice. For me, anything I want to do now, I want to do research for policy and practice. So I will stop here. I know there will be many questions, and then we can pick up from there. If I've left anything out, I'm sure somebody within the audience can actually bring it forth and we can be able to discuss. Thank you very much.
Thank you, Professor Anzala. Always very thought-provoking and always very forthright on the things that are important. And I can see some comments and questions. So I'll pivot now so that we can have a good conversation to look at some of the comments and questions. And if I could start with what I'm seeing on the screen that really resonates with what Professor has just said. The over-reliance of sub-Saharan African countries on WHO and CDC is partially because countries are not investing adequately in research and development and innovation. In addition to human resource, we need infrastructure and systems for research. So that's a comment. So as we think, and I think this is also a challenge to Dr. Kariuki, as you're leading the policy space at the national level and also the research space from a policy and government perspective, conversations around how do we finance our own and have systems so that we can move forward. There's also appreciation there's a comment appreciating the need for preparing communities on upcoming clinical trials for COVID. So that's a comment that's coming from the floor. Let me go back and look at the questions. So I'll pose 2 or 3 questions. We discuss those and then we move to another bunch. So first question here is, and they're not directed specifically to any of the panelists, so please feel free to take the mic as a panelist and respond. What does Kenya need to do to move from dependency on medical product imports to manufacturing its own medical products and ensure equity in access? So that's one. Then the second question is, communities in Africa, including Kenya, have a negative perception of vaccines. How can the country raise the profile of health research and development innovation to ensure communities within the country change their perception of vaccines and clinical trials? Let me take those two. Professor Anzala, do you want to respond to the last one, including on the perceptions around vaccines? And Dr. Kariuki, if you can speak to the issue of dependency on medical products as imports, and how do we grow our own manufacturing? Not just do research, but also be able to manufacture in country. And I also think Dr. Kariuki make a comment on the issue of investment. What steps are being made? I think there is a challenge that's underlying there. So let me stop at that and let the two of you make comments. Thanks. So Professor Anzala first. I think if you're speaking, Prof, you're mute. Please unmute. Professor Anzala, are you able to unmute? The tech lead, are you able to unmute Prof. Anzala?
Let me hear the question again. Sorry, I'm told you I'm so many things. There's a phone call that came. What was the question? I'm sorry.
Prof, so there is a specific question.
Yes.
What communities in Africa, including Kenya, have a negative perception of vaccines. How can the country raise the profile of health research and development to ensure communities within the country change their perceptions of vaccines and clinical trials? So deal with negative perceptions around vaccines and clinical research.
Yes, you see, for us, our experience is vast. We've done so many clinical trials. And these clinical trials, you cannot do without working with the communities. We've set up peer leaders, we have mapped out Nairobi, we have community advisory boards that include community leaders, that include young people. We have just set up a community advisory boards for young people and adolescents.
We cannot hear you. There are voice issue. Hello, Prof, if you can hear me. We seem to have lost Prof. So in the meantime, Dr. Kariuki, do you want to take the question on the issue of dependency on medical imports?
Well, yeah, thank you, Pauline. I think these are important questions that need to be addressed by all of us as a country. I mean, the ministry spearheads coordination of these activities. And it is true that we have for long depended on import of many health products and technologies, whether vaccines, pharmaceuticals, non-pharmaceuticals, implants, and all that. But I think a time comes where we need to start reversing all this. And maybe for the information of everyone, as an initial step, we currently are having most of the supplies being managed or funded by the COVID board that was appointed by the president sometime in April. They are only purchasing locally made PPEs, and health worker associations were tasked to provide members to be able to take our local industries through what quality PPEs are. And I can say over the last 2-3 months, having been personally involved in some of the activities, that we have probably at least a minimum of 8 industries in the country locally that are able now to produce quality PPEs that are being used across the country. And I think this is one of the steps that we need to undertake and to even grow further. In fact, I think one of the factories has already been approached by countries within the East Africa region to also produce for them, knowing that the global supply chain has been affected. So I think if this can be then sustained, we can start seeing the movement of reducing dependency on imports, especially for simpler items that we can start with as we move towards the more complicated technologies. We also know that we have pharmaceutical industry with also a bit of manufacturing. I think we have at least 40 companies locally, and I think this can also be supported to increase the quantities of quality medicines that can be produced in the country. We also have our own CHReaD that when COVID started were the first to produce in mass sanitizers that were distributed across the country, and even in quantities that had not been done before. We think that as part of UHC, universal health coverage, the journey towards universal health coverage, one of the things that was proposed as a must as we get into UHC is a health technology assessment. And I think there's a process currently in drawing up a framework for ensuring that we have a process by which we are able to introduce new technologies in the country. And I think any new innovation that comes up in the country will have a chance to be included as part of this. And this will also help in ensuring that locally, researched technologies are also included in our UHC packages. I think that with this, we will be able to have a very strong local, presence of building our own and building, even our own brands and building things that we believe as a country are good for the local communities. However, this will also be coupled with the other question that you have brought in terms of financing. It also then means that as a country, the whole sector will have to increase the funding that is targeted towards research, whether from private sources, public sources, definitely. We think that probably, allocating part of our finance as government will help, and probably looking at it from the GDP side. If we could say we have X percent, say 2% of our GDP targeting RD&I for and especially for health, getting a portion of that will increase the resources that we can get. Then what we need is to see how the implementation of available resources will be done. Yeah, thank you.
Thank you, Dr. Kariuki. Really good comments, especially thinking about, for us to move forward, we do need to invest, and it's a journey to walk, but that journey must start with some steps. So working towards strengthening local financing. So there are questions that have been raised. This one specifically, I think, goes to D&I. For the communities that D&I works with in conducting clinical trials, what has been the relationship, and what has been done to sustain this relationship? So that's for you, Lynette. The next question is, health R&D has been construed to be a complex agenda. How is CHReaD engaging the community proactively to demystify this fact and engage communities throughout the research process? So that's for you, Professor Bukusi. there's a question from Dr. Amkoye, and I think this goes to Professor Anzala. Is our job to provide data for solutions, provide solutions? How do we close the gap? So let's deal with those three. So Lynette, Professor Bukusi, and then Professor Anzala.
All right, so TNDI carries out its research activities in some of the very remote areas in different countries, and for us to be able to continue conducting these clinical trials and generating evidence that changes policy, we realized a long time ago that we cannot work in silos. So the first thing that we really have done, for example, I can give you an example of leishmaniasis studies that we have done, is work together with the various countries to create a platform. And the platform includes members who are part of that site. It includes ministries of health in the various countries, and it includes researchers in those countries, so local researchers. And that's one of the things that we really need to promote, because this research is for Africans by Africans, one of the things. And I think that's what also Professor Omu was alluding to. So how we engage the communities is through such platforms. We ensure that we engage the communities at the beginning. We are always very open about the objectives of the clinical trials that we do. So we will engage media. We do not fear to engage media at the start of clinical trials. We will engage the community and provide them with, information about the clinical trial that's about to take place. And we will also engage the community in feedback sessions at the end of clinical trials to tell them, what these clinical trials, the results that were gotten from these clinical trials. So we do have that. And we also, in the running of the trial, we have community engagement teams that actually go out to talk about what's happening. And we also ensure that we, as I said before, we work through these platforms and we work with local researchers, even outside Kenya. So some of these local researchers are the ones who will, present to the policy makers. We see the value of working closely with Ministry of Health and other organizations that translate research into policy. So we do, at the same time, work with these local science researchers to be able to communicate with the policy makers. So there's always, other than the feedback we give to the community, we also give feedback to the ministries of health and other policy makers, so that then this is translated to policy change, and we support that process, because we feel that our work is not done until everyone who is involved is actually actually receives the feedback of the clinical trial. And we attempt to go all the way to ensure that actually the medicine that we have done research on gets into the hand of the patient. Yeah, that's how we do it.
Thank you, Lynette. Professor Bukusi, please go ahead.
Thank you very much. I think often when I think about CHReaD, maybe the one thing we haven't done well is to let people know just how much CHReaD does. The depth, the volume, the breadth of work, and all the many things that CHReaD works on to try and improve the lives of Kenyans. And of course, by improving the lives of Kenyans, the lives of people in other places. So what do we as CHReaD do? Now, first, CHReaD has a very rigorous process of approving research. And in the process of approving research, among the things that is very clear is that we look to see how are you going to engage the community. There needs to be a very clear plan on how the community will be engaged. We also look at how are you going to disseminate whatever results you find. Not every piece of research automatically contributes to policy. Not every piece of research finds something positive that can be moved forward. In fact, a lot of research is done that tells us we don't need to repeat that and we don't need to do that again. They inform us what not to do rather than what to do. But every piece of research is important because it adds to the information we have and helps us then find new products, new processes, and new opportunities for improving lives. We at CHReaD do hold people accountable, not just to publishing, because if you do research and people don't know about it, then you've wasted the time and the money. The individuals who've been involved in it, those who funded you, all the people who have worked in it, all the value added that they've put into that work doesn't get recognized if you don't publish it. And we talk about publishing in peer-reviewed mechanisms where people can look at your research and ask questions and ask, did you do it right? Is your methodology appropriate? Are your answers actually the correct answers? If they look at the numbers and they do the calculations themselves, do they get the same results that you do? So CHReaD has a rigorous process of ensuring that that happens. I want to just add to a few other things that I've seen, questions that people have asked, and they're asking, we have a devolved system now. How are we even engaging the counties? Now, CHReaD also has a mechanism where we engage at the county level to talk about research for health. So we have a mechanism that ensures that when we are doing work within our counties, that we can engage the county level. We build capacity for them, we work alongside them to implement the research, and we talk about what are their health priorities. One of the important things that I think the Ministry of Health has done, and I see CHReaD as really the research arm that responds to health issues in this country as being our core focus, is that we now do have some document that tells us what are our priorities. What are our research priorities as Kenyans? And then also talking to the National Research Fund and saying, will you fund these areas? Will you put money into these areas that the government, having considered everything that is ailing Kenyans and that is causing us a lot of deaths and a lot of ill health and stopping us from being as productive as we could, will you then fund, put money into putting into calls where people can respond to these specific areas for them to be able to answer these questions to help us have a healthier and a better nation? Back to you, Pauline.
Thanks, Professor Bukusi. Is Professor Anzala able back?
Yes,
No, sorry,
yes, I'm back.
Oh, we had a specific question for you. I hope you had my question on the perceptions of vaccines. Please go ahead.
Okay, now there was a question from Dr. Mkoe that I'd like to sort out quickly, and then you can then ask me about the vaccine one.
Okay, so what Dr. Mkoe says, our job to provide data for solution, provide solution. How do we close the gap?
Okay, and then the one on vaccines was?
Is communities in Africa, including Kenya, have a negative perception of vaccines? How can the country raise the profile of health research and development to ensure communities change their perceptions of vaccines and clinical trials?
Okay, now for Dr. Mkoe, really the whole issue here is that when we are doing research, there's always a component we call knowledge synthesis. This is now when we bring all that data together as scientists, peer review it, because now we are putting it as knowledge synthesis. Once we have understood it as knowledge synthesis, then now that moves to knowledge translation. So those are the aspects to go to. So we generate data, we do knowledge synthesis, we synthesize it completely, and then we ask, are there pieces and bits in this knowledge that can influence policy? Are there bits and pieces in this knowledge that can influence practice? So there's a bit of knowledge synthesis, and then the next is a knowledge translation. Now, our communities and vaccines. The rain started beating us when the Catholics became vaccine skeptics. And we must talk the truth, because if we don't, then we miss the point. You guys all remember about Catholics and the issues of steroids and the issues of pregnancy. That is where the rain started beating us. And Catholic is a huge community. not all the Catholics, but the doctors. We have never recovered from that, and that problem still continues. So we need to go back and address that, because some of the people who are advocating the issues of vaccines being dangerous and what have you were actually our own colleagues as healthcare professionals, very highly qualified doctors just like all of us. So we need to revisit that and talk about it critically. We have been doing, and slowly, it's actually gaining in a bit of information that vaccines are not really bad for you. Vaccines are good for you. They are highly regulated. And as I've said before, they are given to normal people. And we cite where vaccines successes have been. Polio, you can look at it. Measles, you can look at it. You know, yellow fever, you can look at all these things. So we are now working with communities critically. But on the other aspects of it, COVID has brought another fear. So what we are doing now, we are beginning to package communication that that actually targets communities, because at the end of the day, it will be an individual who will come forth, because they are asking, if the vaccine is available, will you be able to accept to be vaccinated? If yes, why? If no, why? And we address all that. So we are actually beginning that work, because we know it is not just going to be a walk in the park that you get the vaccine and people line up. People might not actually just line up as we think. So we are beginning to translate that. We have been sensing what the communities are saying. All the things communities are saying about COVID, all the things people are saying about how money has been used, and all that has to be addressed to ensure that you move communities closer to where you are, and also addressing the issues that are coming up in terms of COVID publications. I have never seen in all my life the amount of publications that have been published on COVID. Most of them have actually been opinion, but some people actually take it as the truth. So we are also trying to unpack that, to educate the communities that an opinion is maybe class D or class F evidence. We need higher evidence to be able to say this thing works or it doesn't work. So that work has actually started, and we hope that we shall move our communities closer together by just saying what COVID is, what COVID vaccines can do. And also the question they are asking is that, will there be a priority list? Who should be given the vaccine first? Who should be given second? Who should be given third? How do you make those kind of decisions? How will we deal with the vulnerable? Usually we always stay away from the vulnerable groups, but now you realize COVID is across the board. So these are issues we cannot take lightly. So at CHReaD, we have actually started working with the communities just to educate. What we did first is to listen, because what we have been accused for is not listening. But what we have done now, we are listening, and listening very critically. Then the second round will be our ability to go in and begin to respond. And we are working at the level of community advisory boards, the level of peer leaders, you know, where it applies the most. But as we do that, we are also dealing with individuals at the policy level, because there are also skeptics at the policy, at the policy level. Issues of guinea pigs, you had some of our high level people talking that Kenyans cannot be used as guinea pigs. So those words need to be packaged, and information need to be actually be put across that really there's no guinea pig here. These products must be tested, but they must be tested in a very regulated manner before they are introduced to the community. So that's what we are going through. Thank you.
Thank you, Prof. A number of questions. We have only a few more minutes, but we have quite a lot of questions. So we might actually have to ask some of the panelists to give answers maybe later, and those can be included in the report. So let's go off to Dr. Kariuki. We've seen a large discrepancy between policy formulation and policy implementation. What are some of the practical RD&I initiatives from policy implementation angle currently in place to help fight COVID-19 and other future pandemics. So how is research being consumed to inform policy implementation? To Professor Anzala, since vaccine research goes through such lengthy process over years, where are we talking about a COVID-19 vaccine in less than 2 years? So that's a question for you, Prof. Another one is that there are claims that COVID-19 vaccine may not protect the most vulnerable, that is the elderly. How can scientists go about to ensure that the elderly are not left out? So Prof, you have some work for you there. And Professor Bukusi, Lynette, and Professor Anzala, you've all alluded to the importance of financing R&D from local funding and the effects of socioeconomic importance of R&D. Don't you think it is time to do an investment case for it, that's for research, development, innovation, to make sense to GOK and investors? And I think this goes to Dr. Kariuki. How can developing countries cushion themselves from exploitation by developed countries in terms of affordability of vaccines delivered to these countries, especially for COVID? So I have a lot of questions. So please respond to that. But there is one more I wouldn't like us to close without responding to. This is the issue of people who are living with HIV. Will they also be able to access the COVID vaccine, or will they be left out? So both professors, you can respond to those. So over to you. Let's start off with Dr. Kariuki, then Professor Bukusi, and Professor Anzala.
Well, thank you, Pauline, for these questions from the members. I think on the first, in terms of translating policy into research, starting maybe with the COVID situation currently, I think once we got into the COVID pandemic and started implementing our measures, several work streams were formed, and one of the key work streams was the case management work stream, where I think actually Professor Anzala may tell us much more about the work being done there. And I think that's the team that is looking at what research has been done, I think looking at what is happening locally and advising the ministry on the next steps to be taken. So in terms of, even getting evidence synthesized from across other parts of the world, and looking at how ours may project itself over time, and looking at what measures can be taken. And I think in that way, we can say that a bit of the policy decisions being taken are actually being informed from information that has been provided by researchers working within the case management teams, and then moving forward to advise the public on measures to be taken, advising health workers on how to manage the clients they come across. So I think that has started, but moving forward also, we also are in process of building the capacity of the ministry and its SAGAs in terms of knowledge management, and ensuring that any research and any policy that government comes up with has research or evidence backing. And one of the steps that we have taken and we are already working on, even before COVID had come in, is that it will now become, is a requirement that each of the technical working groups in the ministry, irrespective of what it addresses, must have research persons within it, so that for whatever decisions that are forwarded for consideration by senior management and for the sector to adapt or adopt, will have to show that there was evidence that was adduced, evidence was collected from within the country, across the region, and globally, as part of the process to get to making it a policy decision. Right, I think the other question was around exploitation. It was called exploitation, if I got it well. And I think one of the things is to increase our own resources is one. Number two is to be involved in the research itself for the vaccine. I think once a country gets involved in the initial trials, like Professor has said, I think then you get leverage rate for having been part of the group that adduced evidence towards its efficacy in terms of preventing. Maybe that's what I may say for now, but I know the professors within will be able to add more, especially in that area. Thank you, Pauline.
Thanks, Dr. Kariuki. Professor Bukusi.
Thank you very much. I think the questions that I was being asked, in fact, some of them I think have already, Professor Nzala really did allude to them. The case for putting money into research and development has been well made. And I think the government is committed. They have indicated that a certain percentage of our GDP, I think it's supposed to be 2%, will be put into research and development. But remember, that is research and development in general, all, not specifically for health. Out of that, a certain percentage should go to health, but it hadn't been predetermined what percentage. The question is just that the government needs to, as they say, put their money where their mouths are and enable that money to come into research, various kinds of research. And then we need to just make sure from the health perspective that we do have a certain amount protected or provided, a percentage provided to ensure that we can do research in health. The question of people who are HIV positive and them accessing vaccines. Again, Professor Anzala alluded to the process of vaccine development and how long it takes. The goal is to give people vaccines, and as he said clearly, it's not a person who is sick with a particular disease or infection who gets the vaccine. The vaccine is to stop you from getting it. So indeed, yes, people who are living with HIV, the goal would be they also need to be protected from other infections. But we would need to make sure, one, the vaccines do work, and then two, ensure that they're safe and that they can be utilized in someone who may have some level of their immune system having been compromised, so that we can then say, yes, they can go ahead and use it. So it is a process, but it isn't to say that if someone is living with HIV or any other autoimmune disease or any other process that they would be exempted. The goal would be just to make sure they can safely use it. So the process of testing would first be testing among people who don't have something else, which would compromise the ability to successfully be able to utilize the vaccine, but eventually we would get to ensuring anybody who needed the vaccine would be able to utilize it. Professor Anzala, I'm sure I can hand over to you to do an even better job than I have done.
Thank you, Elizabeth. Now, those are good questions. I think this is a good discussion. I'm enjoying it. Now, to start off on people living with HIV, that's exactly the issue. You must ensure that this vaccine is safe. Now, the vaccine, the Ebola vaccine that is now being given to healthcare workers in DRC, Congo, and Rwanda, we tested the vaccine here in phase 1. We also tested that vaccine here in phase 2 to look at extended safety. And when we were looking at extended safety, we brought in children. We also brought in the elderly. We also brought in people living with HIV and AIDS. And we wanted to establish two things. One, is the vaccine safe? Two, does the vaccine give a good immune response, which is actually going to be protective? And the answers on those two levels were actually yes. So for me, really, is a whole issue of what we say, we generate the data and then we synthesize that data. So it is clear you can only be left out if during the process of clinical trials, it is clearly found that safety is an issue in this kind of population. It also leads me now to the issue of elderly. We give vaccines to the elderly. And in fact, now vaccines are not only confined to children, ladies and gentlemen. We are now talking of vaccines for children. We are talking vaccines for adolescent and young people. We are talking of vaccines for the adults and vaccines for the elderly. In fact, now we are saying the elderly people who are 70 should get another shot of pneumococcal vaccine, another shot of DPT, because the immune system has forgotten the previous immunogen that was given maybe 30, 40, 50 years ago. So this information has come in the last few years. So for me, the only group that will be left out is a group that has been identified during the clinical trials that this product is actually not safe. So for now, we are all in, unless otherwise. The whole issue now will just be, how do we prioritize? When that vaccine is available, how do we prioritize who should be given first, who should be given second, and what will be the criteria for that prioritization? And those are the discussions, ladies and gentlemen, we should be having now, as we also ensure that we are part of that process. We are taking part in phase 1. We are also taking part in efficacy. And then the other issue was the issue of COVID in 2021 or COVID in 2020. It's highly likely that maybe it's going to be there 2021. But the reason that COVID has moved fast, first of all, remember where there was an outbreak of SARS-CoV-1, let me call it SARS-CoV-1 in 2000. There was an outbreak of MERS-CoV, both of them coronaviruses, I think in 2012. And between that time, researchers had already started developing platforms for coronavirus vaccines. These are the platforms that were quickly put into process. And they have yielded vaccines very, very quickly. But also the amount of financing that was put in COVID just to understand quickly the natural history has also assisted. So what we are going through is a process which is actually unprecedented, because it is totally expedited process, where they do a phase 1 or they do a combine of phase 1B, and that phase 1B is phase 1 and 2. And then they do a phase 2, but not completely a phase 2. They do a phase 2B, where they combine phase 2 and phase 3. So you are generating data that can give you immunogenicity and safety, but also you are beginning to look at issues of efficacy. And then the clinical trials are designed in a way that there's a lot of redundancy in the way you have your different trial designs. So that you are learning quickly and you're examining that data. If one arm is not working, you drop it and start another arm. So that way you are not going through the standard approach. And then what is also critical is that countries like the US and countries in Europe are actually beginning to give money to manufacture these vaccines at GMP level that can go into human trials should the vaccine work. So this is a risk. US has put in tons of billions of dollars to make the vaccine before even data for phase 3 is out. This is why they are talking of having that vaccine earlier. Standard approach is that you must finish a phase 3 efficacy trials. You must synthesize that data. You must show that indeed the vaccine was efficacious. That is when now you begin the process of good manufacturing practice. But now there are countries that are actually taking up, like US has already given money to Pfizer to begin to make doses. In anticipation, should the vaccine work, then there will be no delay. Those are the issues where you hear people saying this vaccine might be available in 2021. So the step of financing is already there. So even us, we should begin to think of putting a consortium together and beginning to think of mobilizing funds to be able to say, can we also partner with other Africans to put this together to move in the same direction? And that's why we are talking of a COVID vaccine maybe towards the end of the year, because realize the first 3 they are talking about, they want to enroll 30,000 individuals and follow them for a period of maybe 6-7 months. To enroll 30,000 is not a walk in the park. But as they are enrolling 30,000, Pfizer is already manufacturing the vaccine to GMP. If the vaccine doesn't work, that is US money down the drain. Those are the risks some countries are actually taking. Thank you.
Thanks, Professor. Lynette, can I give you just 1 minute to make a final comment? I want to ask the other panelists to do so. We're over time. This discussion is quite interesting and a lot of questions. So Lynette. Parting shot, you're mute.
Yeah, so I think most of the panelists have actually alluded to the value of having a well-informed public. And, you know, public includes the community, it includes the policymakers. And I think if this is done effectively, then we can have more investment. Because how many times have we been able to agitate for the government to make a change as the public, and we have seen some level of change. So I feel that an informed public in terms of health and R&D will actually, it's almost like what I was saying, one impacts the other and the other one impacts the other. So an informed public can cause the government to change and invest more and have more ownership. And actually a government that has more ownership and invests in health R&D will also be able to, you know, have a better access to the publics of new tools and things like that. So for me, I just think we really need to communicate to the public and have them aware. And I'm grateful for all the discussions that we have had today. Thank you.
Thank you very much. And thanks, first of all, to my distinguished panel, also to the participants. It's been a really good discussion. We've got way more questions than the time available. We're now 10 minutes into the next, over time. So I will bring this to a close. Let's keep this conversation going. This is just series 1. We're going to have 3 more. So please prepare to be there. But I think my parting shot, I think, is we need to bridge policy, researchers, communities, advocacy, media, and communications to ensure that all things are working together so that all the country can benefit and be driven by research. Thank you very much. I'll not take any more of your time. Have a good evening, and we will discuss further on the next webinars. Thank you. God bless.
Thank you.
Bye-bye.
Bye-bye. Bye, everybody.
Bye.
Bye-bye.
Bye-bye. Keep safe.
Bye.